The floor is yours.
Thank you very much and welcome everybody. My name is Nicola Battisti. I'm a breast medical oncologist at the Royal Marsden Hospital of London in the UK. I'm the president of SIOG, the International Society of Geriatric Oncology, and I work as a consultant with the Anticancer Fund. Shared decision-making is a universally accepted approach in oncology, achieved when patients are fully informed of the treatment options and the trade-offs between risks and benefits, and the value and preferences are taken into account into treatment decisions. However, when we care for all the patients with cancer, this may sometimes be easier said than done. How do we approach shared decision-making in the context of a higher burden of comorbidities, competing risks of mortality that we typically observe in this patient population? How can we navigate shared decisions if the patient has advanced cognitive impairment? Can we leverage frailty geriatric assessment to better inform shared decision-making in this patient population? How do we deal with the concerns, preferences, and potential assumptions of their caregivers? Achieving shared decision-making in oncology yields significant additional complexities in older patients with cancer. Therefore, I'd really like to thank SIOG and the Anticancer Fund for organizing this webinar, and the EU DG Santé and the Health Policy Platform for hosting it today. Our webinar aims to provide answers to many of these questions and initiate a discussion around these complexities. I think we have 37 delegates online now. I think we had more than 90 participants and a fantastic lineup of speakers and panelists. We will start with Dr. Edgar Ekman, founder of the Patient Empowerment, that will talk us through the role of power dynamics in the care of elderly patients. We'll then move on to hearing about the Anticancer Fund My Cancer Navigator and how tailored medical information can help patients better understand the treatment options with its coordinating physician, Dr. Gabri Kuiten. And finally, we will have a panel discussion and Q&A moderated by Dr. Sergio Crispino, scientific consultant of the Anticancer Fund, and we will benefit from the input of a diverse and multidisciplinary panelists. Professor Siri Rostoft, a geriatrician at the Oslo University Hospital in Norway, and representative of the Geronte study. Mr. Ray Gardner, member of the Patient and Care Advisory Group at the Royal Marsden Hospital of London, UK. Michelle Hanahan, advanced nurse practitioner in geriatric oncology that coordinates the Geriatric Assessment and Liaison Clinic at University Hospital Waterford in Ireland and is a member of our SIOG Nursing and Allied Health Group. And Dr. Anneke van der Wal-Jusman, research nurse and nurse scientist at the Dutch University Medical Center in Groningen, Netherlands, and also member of our SIOG NIH group. Without further ado, let's now start with Dr. Edgar Ekman, that will present on the role of power dynamics in the care of elderly patients. Thank you very much. The floor is yours.
Thank you very much, Nicolo. Indeed, power dynamics play an important role in healthcare in general, but certainly in the healthcare for elderly patients. And I think an underestimated role. And it's directly related to the concept of patient empowerment. And patient empowerment is a must. It's not a free choice. And that is related to these power dynamics. Allow me to give you 3 reasons why empowerment is a must, and taking these power dynamics into account is a must. Why? 3 reasons. My first reason: healthcare, and also for elderly patients, is a matter of respect. And you may say, well, it goes without saying, yes, but sometimes the power dynamics influence that amount of respect in a negative way. What kind of power dynamic does exist in this relationship? Think together with me. It is about power. But what happens when a patient, you see here on the screen a caricature, a patient, he's called Elton. What happens in the life of Elton when he learns that he is confronted with a serious disease and he wants healthcare. What happens? A lot of things can happen. But one of the things that happen is that Elton becomes dependent. Dependency. Dependency is a key element, a key aspect of these power dynamics in healthcare and also for elderly patients. Very often, the first person he becomes dependent on is this guy, the doctor. Yes, the person who prescribes the treatment, who prescribes medicine. And is Elton dependent on the person itself? No, he is dependent on a certain number of resources that the doctor possesses, of which a patient depends. A patient or a healthcare receiver, because it's not just in a hospital, it's also in mental health, for example. What resources think together with me, what does a doctor possesses of which a patient depends? I'll show you the resources I have identified in my PhD. Information goes without saying. Knowledge, two different things. What you find on the internet is information. Very often it seems that research shows that patients print information from the internet and need the doctor to get context. So they still need his knowledge and his expertise. Time, a rare resource in healthcare. Attachment and affection, trust, these are elements of the quality of the relationship, the interpersonal relationship. If a patient has a good relationship that creates mental comfort, it makes dependent. The evident skills of the doctor, of course, his skill to develop treatment, to make an analysis, to do research, the evident skill of the doctor for an operation or the surgeon for an operation. And then the legal prerogatives of a doctor, of the medical profession as a whole. A patient can't do without it. And a patient knows that he's dependent on these resources. So when you get ill, you want healthcare, you become dependent. And if the resource is valuable and rare, the dependence increases. I mean, when you have a cold, you need information, but you know more or less what you have. If you have a rare disease, then your dependency on information and expertise increases. And if there is uncertainty, and you have, as a patient, you perceive what you have as risky or serious, perceived risk, perceived seriousness, perceived by the patient, the dependence increases again. Even trust again creates comfort, mental comfort. And if you have a trustful relationship, you don't want to harm that relationship, it creates a certain dependence. So you become ill, you become dependent in the first place of the doctor, but the same goes for other caregivers. You become dependent on these resources, and if it's a severe problem, the information or the knowledge or the skills are rare, you become even more dependent. It is dependency power. It's not this classic power that's related to coercion. No, that is the definition of power as we define it very often. But this is dependency power. And it's important to realize that that kind of power exists because it exists under the skin. You know, this classic power, you feel it. It's, for example, military power. You know that, if you say the truth, you get problems. This is this kind of classic power. But the patient going to a doctor needs the doctor. The dependency power is implicit. If you want to know what a patient thinks or plans to do after he knows what treatment to follow, you will have to ask him. He is dependent. It influences his information and his communication. Why is it important? Because Many studies show that the loss of self-control and autonomy that you live when you become dependent, that it creates helplessness, that it can create anger, passivity, that it creates resistance. There are even studies that say that patients become even more sick due to the feeling of dependence. And of course, for elderly, imagine, you know it, if you are alone, if you know that you can't count on anyone else, you are in a rest house, for example, and you are sick, or in the hospital, you don't have family, you have no way out of your current living conditions because the restroom is your only solution for the rest of your life, or you have the feeling of not having the courage of the strength to resist, or you feel that the physical or mental condition makes you dependent, well, the dependency becomes even, increases even. And I must only say that for this target group, misusing that dependence, that dependency power, I consider it as really extremely unethical, because as a caregiver, you are confronted with people who are sometimes extremely dependent. Of course, there is a balance. A doctor, for example, the caregiver, a doctor depends on his patients. He needs the information of the patient. He needs the time of the patient. The quality of the relationship works from both sides. And of course, a doctor needs the patient for his income. But for the patient, the relationship starts in a situation of dependence because you go to the doctor because you need help. The start is dependence. And secondly, because for the patient, the consequences of the disease are much more far-reaching than for the doctor, who could lose a patient and who could lose a bit income, but then another patient arrives and it's again, he has another patient. But for us, for the patient, it is much far-reaching, which means that in the relationship, the balance of power based on mutual dependency is uneven. It's not in balance, yes? And I'm now talking about the interpersonal relationship, but of course you have the system, you have the healthcare organization where a patient depends on. So it's not just something that plays on the interpersonal level, it's also on the level of the meso level, what I'm calling meso level, the healthcare organization, and the macro level, the healthcare system. So there is an unbalance in dependencies. And this is patient empowerment. An empowered patient has control or a feeling of control over the management of his condition in daily life. Not just control as much as possible, of course, but also the feeling of control, because you know as well as I do that we can't control everything. It's an ideal to control everything. So sometimes a patient will always remain dependent on the legal power of a doctor. But by communication, you can give a patient a feeling of control. Of course, there are conditions. You need a patient with a willingness to keep this autonomy and the competence. I'm coming back on this briefly later. So briefly said, there is a power dynamic based on dependence. You lose self-control as a patient. And what is patient empowerment? Restoring, maintaining, and even strengthening the feeling of autonomy and control. And this is done by communication, by the way we behave towards the patient. We try to give him a feeling of self-control. And which means that for me, the conclusion is, due to these power dynamics, we don't just have to give a patient the best healthcare. Of course that we have to give him the best healthcare, but we should also try to restore, maintain, and strengthen his autonomy. And that is related, and we have to do it because it's also a matter of respect. And it's based on 1,000 small things. How do you enter the room of a patient? How do you touch the body of a patient? How do you speak towards a patient? How do you call a patient? I mean, a lot of behavioral elements give the patient the feeling that he is the key person in the healthcare process. And these are trust points. Every contact that the patient has with the caregiver confirms that the patient has reasons to trust his caregiver or not. Reason 2, briefly. Let's look at the reasons, the motivations, why the important advantages of patient empowerment. Preventing a patient from feeling even worse because of feeling of dependence. I did talk about it. But in a healthcare where self-managed becomes more and more important, of course that you need an engaged patient. And if we want the highest possible adherence to the treatment, we need an engaged patient. And if we want people to prevent illness or to prevent getting sick, you need an involved and an engaged patient. So it's not a matter of free choice. You need the engagement of the patient. And I can imagine, I didn't research that, but I can imagine that if you decide together about the treatment, that you have fewer conflicts because you shared control, you shared responsibility. Reason 3, these are the times it's done, it's gone. I remember my mother saying when I said, why do I have to do that? Because I say so, my mother said. Well, people accept this less and less. And this is an expression, a quote of a patient. It is my body. And honestly, patients are right. It is their body. They have to have the final say. I let you read this quote. Is there any reason why we should accept in sickness what we would never dream of accepting in health? And this researcher, Caroline Folder, in her book, Whose Body Is It?, is totally right. And why? The answer, I gave you the answer. Why do we accept it? Because people are dependent when they become sick. And this means for me that we should arrive at this kind of paradigm shift. No, not the patient in the center of his healthcare. No, not the patient as a partner of healthcare process of his health. No, the patient as an owner of his healthcare process. Just like someone building a house and he will have to or she will have to live in the house, she has the final say, but of course she works together with other experts to help them the best possible house to live in. The patient as an owner, giving him the feeling that he is the owner of the house. That is giving feeling of self-control to the patient as an answer to these power dynamics. And I will end this short discussion about the power dynamics with another keyword. We had respect. Another keyword is together. I do not consider the patient a client who is always right. No, they have to do it together. Caregivers, care organization, the healthcare system, and the care receivers together as equal partners. That is the objective of patient empowerment, and therefore is a must. You cannot do it without the patient. And therefore, it is important to be aware of these power dynamics. I thank you very much for your attention.
Thank you very much, Edgar, for this fantastic talk. I'm sure there will be so many points that we will discuss during the panel discussion and Q&A that you touched upon. It was great. I'd like to invite the next speaker on the stage now, on the virtual stage, Dr. Gabriel Kuitien, coordinating physician and My Cancer Navigator. Gabriel will talk about the My Cancer Navigator experience, how the team is tailoring medical information to help people better understand the treatment option. And this is obviously so relevant also for the older patient population. Thank you, Gabriel. The floor is yours.
Thank you, Nicolo, for this kind introduction, and thanks everyone for being present in this webinar. So indeed, I am the coordinating physician of My Cancer Navigator, an information service for cancer patients. And My Cancer Navigator is a service that's made possible by the Anticancer Fund. The Anticancer Fund is a non-profit organization based in Belgium, but with an international scope. And we have two main areas of focus. On the one hand, we support clinical research that is not of commercial interest, but that is of medical and clinical interest. We have our information service, which I will talk about a little bit more, and we do policy work mainly at the European level to promote the two other areas, and also with focus on access to care. So, as I'm sure all of you in the audience know very well, when somebody is confronted with a diagnosis of cancer or even a cancer treatment journey, there's lots of questions that arise. There's lots of information coming to these people, and it's not always possible in the span of a consultation with your physician, with your nurse, with your entire healthcare team to get all your questions answered. Sometimes the questions come later. Sometimes people are afraid to ask questions. Sometimes emotions are so overwhelming that they don't capture what they are being told. And so with My Cancer Navigator, we aim to support people in navigating all the information that's out there. So how do we do that? Well, we deliver independent, personalized, and evidence-based information when people have questions on treatment options. You know, for instance, they have a scan coming up for a next evaluation and they want to know what else could be done if the disease is progressive. Or they want to know, are there clinical trials that I could be eligible for? They want to know sometimes, am I in the right hospital? I'm in a small peripheral hospital. You know, should I be going to a center of excellence and where could I go? Or they might have questions on what we call non-regulated therapies, which could be anything from expensive cell therapies offered in private clinics that have not been proven, or supplements, or vitamin C injections, or all kinds of things that have either not been studied enough or have not yet been approved, or sometimes we don't know anything about, but we can help them sort the information on those topics as well. Now, this is always guided by the questions that people come with. So we don't go out there and say, oh, here's everything you need to know about breast cancer or colon cancer. No, it's very targeted to the questions that they have, and we do not give advice. So we're going to say, okay, this is the information that's out there. If you wish, you can discuss this with your physician, with your nurse, with your team, your GP, and we can support them even in how to have those discussions, with the ultimate goal being informed and shared decision making. So it's something that helps balance that power imbalance that we saw in the previous presentation a little bit more towards the patient, where there can be a more engaged and informed partner in the process of shared decision making. So briefly, the process on how it works. So a patient or somebody on behalf of a patient, and this could be a relative or friend, but also a healthcare professional, of course, always with the agreement of the patient, can contact us. And the first thing that will happen is one of our physicians will contact the person to have an introductory call. This is to have an understanding on what the situation is, what the diagnosis is, if they already have a diagnosis, what tests have been done, maybe what treatments have already taken place, and of course, what the questions are. And also, what is the question behind the question? We often get people contacting us. I've heard about immunotherapy. Can I get immunotherapy for my cancer? And then we try to find out, okay, what have you heard? What have you read? What kind of immunotherapy are you referring to? Are you concerned about the therapy that has been proposed to you? Do you have questions about it? Do you have fears around it, etc.? So we try to clarify all those things. And then we, of course, also explain how we work. We do ask that the patients share their relevant medical records with us, because that will allow us to give the personalized answers that they need. And they will, of course, have to sign a consent for that, in agreement with our policy around how we treat those data. Once we have all the information, one of our research managers will start a literature search, and this could be looking into guidelines, looking into the scientific publications, clinical trial databases, etc. Once we have gathered all this information, we'll have a team meeting where we work, we meet with our physicians, our scientists, and also two consultant oncologists who are also in this meeting, namely Nicolo and Sergio. And they will provide their input from a clinical perspective on the questions that the person had. Subsequently, we write a summary where we also list all the references that we've used in an understandable language, and we'll have another call with the patient to discuss what we found. If there's any additional questions, we start over or we repeat part of this process. The service is free, and our organization is entirely funded by donations. So just very briefly, not going over all of the names, but just so you have an idea, we have 4 medical doctors who are in contact with patients, 4 scientists or research managers who do the searches, 5 specialists to give their clinical input, and 1 medical director who supervises our service. So we have a good, solid team of people supporting this service. So in the past year, we've been lucky to have a student from the University of Leuven work with us on his master thesis, who did a study using a survey to measure the impact of My Cancer Navigator, as well as the satisfaction of patients and other people who contacted us. And those results are as yet unpublished. So I'm just gonna share them briefly with you, but the data are still confidential. We're working on a publication. So what we see is that in all, 77% of patients had a positive impact, experienced a positive impact on emotions. And these were things from having more hope, being more optimistic, to, you know, feeling less anxious, feeling less sadness, etc. 86% of people had experienced more knowledge. So depending, of course, on the questions they asked, but this could be in terms of treatment options, clinical trials, management of side effects, etc. Importantly, also 40% of all the users had a positive impact in terms of communication, both with their healthcare providers and their family and friends. And 60% of all the patients who responded to the surveys had a positive impact on discussing their treatment preferences with their healthcare providers. So, and of course, we think that is an important contribution to shared decision-making if people feel more comfortable to sharing their values with their healthcare professionals. So we also look to see if people experienced an impact on disease management. Now, this was broadly defined in the survey. One of the ways that we said the management could be impacted is that the person was able to make a decision. Many times when we get contacted, people are unsure of what they should do. You know, sometimes they've literally been told, okay, we can do A or B, you choose. Or at least that's how they've perceived it. That may not have been what they were told, but that's what they felt, and they feel very insecure. And then if we help them put things next to each other and, you know, look at pros and cons and what data there are out there, it makes it easier for them to make a decision and also discuss that with their physician or nurses. Sometimes there's an actual change in treatment than what was originally planned. Sometimes people have decided to go to a different hospital or contacted a center of expertise for a second opinion. Now, just to be clear, this is something that we rarely proactively suggest because we do not want to interfere with the physician-patient relationship. And, you know, it's very important that that is respected and maintained as well as possible. But most of the time when these things occurred because people had questions about that and were asking, where can I go, or should I go get a second opinion, etc. So just, some things that people commented in the survey that illustrate a little bit the impact it had for them. I'm just going to read it out. So one person said, after I presented the information that I had received through my Cancer Navigator, the physician became more open. She found that I show a greater interest in my treatment options, and so she has become more open and gives more explanations and details. Another person wrote, the information that I received from my Cancer Navigator is of scientific quality, enabling me to back up the discussions and requests with more precise and relevant information. In this way, I can obtain more effective feedback from my doctors, and the consultation is more personalized now. So when we look at elderly patients specifically, in my Cancer Navigator, we look back over the past year, starting in September 2022, and we note that about 20% of people that we supported were over the age of 65, and a little less than 10% over the age of 75. Now, for those patients, in 56% of the cases, it was a relative or other contact person who was in touch with us about the patient. Whereas for the whole population, in my Cancer Navigator, that number is about 40%. So, not unsurprisingly, it's more often for elderly people that somebody else will be managing or co-managing the disease and the treatment trajectory for them. So what barriers do we experience when we support elderly patients? Of course, since we are not actually treating the person, we're not seeing them live in front of us, it's not always easy to have a good feeling of how fit they are, for instance, and how able they would be to undergo a certain type of treatment, whether they might qualify for a clinical trial, and also to understand if they are really understanding everything. Sometimes there could be a language barrier on top of that. Sometimes there could be some cognitive issues on top of that. And of course, all those things are more complex when we don't have a face-to-face interaction, but we're having a video call or sometimes a phone call. Or of course, when the contact is through a relative, we don't always see the person themselves. And even though we ask that the patient themselves give consent, we don't always necessarily know what the patient wants, even if we're asking, okay, what did your mother say? What is her preference? What, how have they spoken about these types of choices before? We still get it filtered through the perception and the feelings of the relative. Also, the position of the relative in the family is not always clear. It may be a cousin or a sister or a child, but that may not necessarily be the person who's closest to the patient. But it's always difficult to get a good feeling of that. And then sometimes the patient and their relative are not even in the same country. So it may be, somebody has moved away, lives in a different country. There's often a lot of guilt and a lot of responsibility that people are sensing, and and they contact us, and they may not even have a good grasp on exactly what's going on with their relative that they're contacting us for. So maybe to illustrate, I'd like to talk about a few actual situations, of course, a high level to protect privacy. But this here is an example of where our impression was that the son who contacted us for his mother was leaning towards over treatments, if you will. Sometimes it's the medical professionals who are leaning towards over treatment, but here it was the child who was in a different country. His mother had inoperable bile duct cancer, And she was being managed according to guidelines. She was going to start chemotherapy, which was standard of care. But this son had researched a lot of information on repurposed drugs, off-label medications. And although there's a lot of research ongoing and a lot of interesting potential, for the most part, these regimens have not been proven to work. And same goes for, many supplements. And somehow he had actually obtained those drugs, even though he was not a physician, and he was giving them to his mom. And he asked us, okay, what repurposed drug cocktail can I give? What combination of drugs, what dosages, etc. So, of course, we made it clear that, there's no such thing that we could provide him with, due to the lack of evidence, very limited data. We did do the research to show, okay, what is available on the drugs that you're interested in, what is available in information. It was mostly preclinical, very limited. And we urged him to, really discuss with his mother's doctors, whether this would appear to be a good idea, whether, there might not be interference with the chemotherapy that she was getting, because it's older drugs that there's no side effects or no interactions. So ultimately, he decided, presumably with his mother, to stop all the medications while she was receiving the chemotherapy. So in this case, that felt like that was probably a good and safer move for the patient. Now, another example is of a patient where possibly there was a situation of undertreatment. This is an 80-year-old gentleman who had an esophageal tumor. The contact person was his son. He was a very fit person, very socially active, living by himself, who started having difficulty swallowing. And he was found in a smaller hospital to have an esophageal tumor. They did additional testing, which showed no further spread. He got a stent placed and was sent home to come back for follow-up in 3 months. And they contacted us asking, is that really all that should be done? Is there anything else that could be considered? Is he really not a candidate for surgery, etc.? So in this case, of course, an assessment on whether somebody's a candidate for surgery is not something that we can do in, in our type of service and in our assessments. So what we could do is say, okay, the guidelines say that, in a fit person, usually, they would be assessed for fitness for surgery, and it could be an option. So they then decided to go to another hospital, a larger hospital with more expertise, and it was decided to operate on that person, and he did really well. And he actually had a good quality of life for quite a while afterwards, where he was still able to go out for dinners, still able to, go out and have his social life. So, here possibly it was felt like, okay, he's 80 years old, we're not going to do too much. He's probably not going to be fit for surgery, but really, it probably was better to evaluate that more on an individual level. Again, my disclaimer is we don't speak with the doctor, so I never know what goes through their heads. So some of these things are assumptions, of course. Last example was of a 72-year-old lady, also very fit, who had early stage breast cancer. She contacted us herself. She'd already undergone surgery and radiation and was wondering, do I really need to have all this chemo and anti-hormonal therapy? I'm very worried about my quality of life. I still travel right now. I still do a lot of things. And, what's that going to do for, for my activities and how I'm going to live my life? And what will it bring me in terms of risk reduction, and how much longer will I live, and what is the reduction of risk of recurrence? And so we looked up the numbers for her, and, with all the detailed information, of course, from her diagnosis. And it turned out that, if you really look at the numbers, her life expectation in 10 years would increase from about 90% to 93%. And so for her, you know, that was very significant. I don't know yet what she decided to do, but she felt like that's not a big percentage. There's a good chance I might die of something else. You know, 10 years is a long time. Maybe I'll consider taking that risk. And if I do have a relapse, you know, we'll take it as it comes, but I might just enjoy my life without these medications for a while. And here too, this is a question of, you know, personal values that may not be aligned with, you know, guidelines and standard of care, but, you know, are very important to the person themselves. So in conclusion, as we all know, and we have a fantastic panel here with lots of experience in the area as well, older patients have very specific challenges in their treatment journey and shared decision-making. And while within My Cancer Navigator, we also get confronted with these specific challenges, we can provide support by providing independent information and improving communication. Thank you very much for your attention.
Thank you very much, Gabby, for the excellent presentation. I think this was very good to hear. You know, your hands-on experience with the excellent work that you're doing within the My Cancer Navigator, and brings us back to what Edgar was saying about communication as a way to really empower patients to make decisions that are right for them based on their preferences and so on. So that was great. It's now time to move on to the panel discussion and Q&A. This is going to be chaired by Dr. Sergio Crispino, consultant at the Anticancer Fund, and we will have our panel members, Professor Rostov, Mr. Ray Gardner, Mrs. Michelle Annan, and Dr. Anneke van der Waal-Oosman, that I'd like to invite on the floor, please. Thank you.
Thank you, Niccolo, for having given me the opportunity to chair this session. As Niccolo said, I am Sergio Crispino from Siena, Italy, and I am a medical oncologist and a scientific consultant at the Anticancer Fund. The aim of this session is to focus on a discussion some of the aspects related to the shared decision-making process in older patients, trying to break out specific, I mean unique, needs and try to highlight possible suggestions for future action. With me, as Niccolo said, there is Ray Gardner as patient representative. Morning and welcome, Ray. Sir Rostov as geriatrician. Morning, Sir. And as a nurse representative, we have Michelle Annan and Anneke van der Waal-Oosman. Morning and welcome to both. Just a minute to explain how we will proceed in this session. I will pose some questions to each individual panelist, and after the answer, the other panelists will be able to ask questions by booking themselves through the raised hand icon on the screen. In addition, all participants from the audience are invited to ask a question, and they can do it through the chat. This question will be selected and then submitted to the panelist or speaker. So all are welcome to participate in this discussion. The first question is for Ray Gardner. Ray, you are an experienced patient representative, a member of the Patient Care Advisory Group at the Royal Marsden. The first question will focus on needs, identification, and unnecessary stress. So the question is, how should the needs and preference of individual patients be identified without causing unnecessary patient stress? Right.
Well, thanks. I'm not sure whether I've got the easiest or the most difficult question to start with, but I'll give it a go. A little bit of my background. In 2018, I was diagnosed with myasthenia gravis. It was a disease I'd never heard of. I put all of my trust into the doctors. I went to the hospital. I had a course of treatment given to me, and I just got on with life. 3 months later, I was diagnosed with prostate cancer. The chances of me surviving both are about the same, or not surviving both are about the same. My reaction to actually being diagnosed with cancer was entirely different to being diagnosed with myasthenia gravis. My world fell apart, and the stress level went through the roof. So when you talk about stress, I think it actually starts from the very point that a patient is diagnosed with cancer. And so when we talk about managing that stress, I think we first of all have to think about whether a person needs managed shared decision making as an assistance tool, or whether they can manage themselves. So there's if it needs it, at what point in the treatment process that patient should actually receive it, whether it's once or whether it's continual, and also who should be included in the discussion when the patient has that conversation with the doctor, who's there. Is the patient there with their family? What part of the family are there? How do you decide who in the family is there? And when you have people in that conversation, who is qualified to actually manage and counsel both the doctor and the patient in terms of potential contradictions in what is being heard by the family and by the doctor? How do you actually educate the patient's family in terms of asking the right questions or understanding? I think there is an assumption from what I've heard so far that the people all have the intelligence to be able to ask the right questions. And I don't necessarily think that that is the case. And so for me, the stress levels, people may be ignorant of stress because they haven't actually asked the right question. And managing the stress is going to be a consequence of asking the right question and getting the right answer.
Thank you, Ray, for this interesting answer and for showing us how to try to deal with this delicate aspect in order to limit the unnecessary patient distress. Undoubtedly, it's a very difficult and complex question. Are there questions from the panelist speaker or from the audience?
Maybe I could just add something into that as well. Something I didn't mention was my wife was diagnosed with Parkinson's disease 15 years ago, and I came in as a patient in all of this, but my biggest concern was actually my wife. And so how to manage her was my biggest concern, not how to manage me. And it puts a completely different spin on the conversation that I would have with the doctor compared perhaps to some other people.
Thank you. Oh, I think that we can move to the next question for Siri Rostov. And with him, we would like to address another interesting topic, namely the problem of main barriers. Siri, as a geriatrician in Norway and part of the Geronte Project Consortium that is preparing an innovative, cost-effective, patient-centered holistic health management system. What would you say are the main barriers to achieving shared decision-making between all their cancer patients and their health providers today? And also, how do you experience it yourself? And what difficulties do you see among your young colleagues or co-workers?
Okay, thank you. I've been thinking about this, the main barriers, and I I picked up 4 that I would like to go through. And I think one main barrier is still the culture, both among physicians and patients, that patients don't expect the doctor to start asking them what they think about the treatment, maybe especially in older patients who have been used to a more paternalistic way of looking at the doctor as the one who knows best always. But I also think you said the younger doctors, I don't know if they are the, but also older colleagues are not so used to this culture. So I think that's a main barrier, but also awareness. And looking at myself, I was becoming more and more aware about shared decision making only embarrassingly few years ago, even though I worked in geriatrics for many years. So, and I realized what a great help it is for me as a clinician to discuss decisions with patients. So that's one thing, the culture and awareness. And then also communication skills, because it's not so easy. It's been discussed already in the former presentations. We don't really know how to do it because we're not trained in how to integrate the patient's preferences into the decision making, and there are many misunderstandings that the patient is supposed to choose the treatment, but they are not the experts, so how can they choose? So you need to be able to communicate about it. And then I think in the context of geriatric oncology, it's the lack of geriatric assessment. It was also discussed earlier. What is the fitness level of the patient? What are the impairments that might influence the decision making? And to have a broad assessment of the patient with strengths and challenges, so that it's easier for us to discuss, to do shared decision making if we know more about the context in which the patient lives and how their life, what their life look like, what are their priorities, those issues. And that's what's one of the main things in this Geronto project that you mentioned briefly, where we try to integrate geriatric assessment into the decision making, both to be available for the doctors who make decisions and also to know something about the patient preferences when you make decisions. And then the 4th element, lack of time, is a big issue. I think we haven't scheduled our appointments to integrate shared decision making. So those 4. And I must say, I still experience quite frequently that the patient tells me when they are sent to me for a geriatric assessment as part of the decision making that, well, the doctor told me I have no choice about treatment. So that's not a good start for shared decision making.
Thank you, Siri, for having well highlighted these critical aspects. And the lack of time, I think that's an important aspect. And these difficulties, I think that could have a clinical and organizational impact. Are there questions from the panelists or speakers? And if not, we can move to the third question.
Comment. There's a comment
yes.
in the panel.
Yes. Okay.
Yes, Siri, thank you. I was wondering the aspect of culture you describe. What do you suggest regarding education? Do you think education can be the solution to it? Also in medical education upfront?
Yeah, I think that's one of the main points because I feel that's where we can make a difference by teaching the students, the medical students and nurses and whoever is healthcare professionals to integrate what was talked about earlier. The patient owns their body, so it's very natural to respect them and to integrate this into how you make decisions, and the way the medical studies, at least in Norway, are organized is not about that, but it really has to be emphasized on all levels. And also I do a lot of talks about this with doctors, and I ask them, how do you do it? And they have a lot of different ideas, and just to discuss this and to bring it on also into all my conclusions. If I see patients for cancer treatment, I always bring in the aspect of the patient's preferences into my conclusion. So there is an element of teaching one another about this aspect, I think, is important.
Siri, just a specific question on the lack of time, because I think that in the clinical practice, this is a very important point, because when you have a discussion with the patient, it means that in the general practice, usually this will end after 15, 20 minutes, and several doctors say that they do not have time to discuss deeply several aspects. What in your practice this point could be relevant and how much?
Yeah, so in my practice, I have more time because I'm a geriatrician, so we have more time for each patient. I think this is a structural big problem. And the argument that we don't have time to assess and discuss with the patient thoroughly, but we push them through all kinds of super expensive workup and treatment. It doesn't make sense. If it's cost, that's the issue. But that's so we have to keep working on the structure, and maybe one solution to do some kind of screening, for example, for frailty, where we know the risks are higher, then you need patients who are older with a lot of issues. You just need more time to make that decision, because otherwise you might end up with, for example, overtreatment that will be very costly. But it and also to collaborate about shared decision making with the nurses. If it's more resources there to just integrate it in the whole treatment trajectory, could also be a solution, I think, not to leave everything on that one consultation with the doctor.
Okay, thank you. I think that there is another question from Ray. Is okay, Ray?
Thank you. Siri, you talked about educating the professionals, but isn't there also a case for educating the patients and the family as well?
Absolutely. I think, because they look at me surprised if I don't frame it the right way. And I say, well, it's not about, I tell the patients, it's not about you choosing treatment for you came to the specialist, and this is very advanced now. Even I can't mean so much about cancer treatments because there are subspecialists within oncology who make treatment decisions. But tell me about your life and what is important to you. So, and that's your role as in the shared decision making, to tell me about you. So I think that's really important. And if patients and also caregivers are educated on this issue, they will request shared decision making. You showed some numbers from your organization that after getting more information, 40% had more positive communication, and I thought that was kind of low. I would hope that 100% had more positive communication and shared decision making if they know more about their disease. So I really think there is a huge improvement, room for improvement on this.
Okay, thank you. So the third question is for Michelle Annan. Michelle, you are an advanced nurse practitioner coordinating the geriatric assessment and the liaison clinic at the University Hospital Waterford in the Ireland. With you, we want to explore the concept of different perception of information. The question is the following. We often see a different perception between the treating physician, who thinks that the patient is well informed, and the patient who clearly is in need for more information. Is this the same for elderly patients compared to younger adults? And why this gap?
Good question, Sergio. And I think it's fantastic that we have an opportunity today to have this conversation, and thanks for having me as part of the panel. And yes, I suppose, I do believe that older adults have the same issue. And I suppose the literature will tell us that there's a disconnect between patient preferences and what healthcare professionals perceive as their preferences. And I think that, it's an equally important, but it's also a very complex issue when it comes to older adults with cancer, as their needs or priorities can be very different to that of younger adults. I suppose older adults will often value quality of life, function, having the ability to attend important family or social events over risk and side effects that, you know, may impact that from a cancer treatment. And as Ray mentioned as well, you know, patients are all individual. They come with lots of different backgrounds. They have lots of different responsibilities, maybe carers for other loved ones for whatever reason. So I think, you know, it is an important priority. You know, living longer for some patients isn't the goal. Having quality is more important. So these priorities just need to be part of the conversation, I think. I suppose, why do we have this gap? Again, I think we need maybe to consider the information needs as an individual and that they're very multifactorial. We can know that some patients will arrive to clinic alone, some will come with family members, some will want to know everything, some don't want any information, they want very limited information. And I suppose before a physician appointment, the patient may already have their mind made up. They might just, without the information, they may not want any treatment. And I suppose then, you know, they come with family members who will also have questions, maybe encouraging the patient to go for treatment, that kind of thing. So I think first and foremost, it's very important that we listen and respect the information that we receive from the patient and the family and their preferences. And back to our first talk at the patient empowerment, I think it's really vital that we as healthcare professionals provide concise information to the patient and the family, engage it at the needs that they want so that they have the information to think about the decision that the physician has given them and to make that choice, because it is very complex. And as Ray said, it's very stressful attending medical appointments, and it's sometimes hard to know what questions are the right questions to ask. I suppose in ways for us to help improve this gap, I think we need to further research again, as it's an age-old question, that we need more representation from older adults on clinical trials. Like, we know that older adults that do participate are generally the fitter older adults, and they're not necessarily the general population that we see. So, you know, knowing the specific outcomes of how patients tolerate treatment so we can better give information to our patients. More information again on shared decision-making tools and how to integrate them easily within, so education. I suppose, as Siri mentioned, we need more and greater access to specific clinics dedicated to older adults with cancer to help support older adults with cancer and their families. We know that comprehensive geriatric assessment is gold standard, but and the assessment results gave us an opportunity to get more information on the patient and have an opportunity to talk and to give greater information to the patient and the family and treat them as a person globally. It allows for greater, I suppose, conversation regarding the risks and benefits and the concerns we would have that would impact the patient's treatment or their function and their quality of life. And I suppose overall, it allows for the development of individual patient plans with the patient as an integral player in that plan. And I suppose just to kind of round off, sorry, I'm probably going on a bit, but finally, I suppose, like, you know, being aware and asking if the patient has any barriers to communication, vision, hearing, cognitive issues, and, you know, literacy issues, that we target our information towards that. Ensuring that we involve family members or caregivers that are important to the patient if they want them involved, asking patients about their priorities and using the shared decision-making tools if we have if they're part of our clinic, whichever ones I suppose are recommended, and then with information given considering time. We know that, you know, the physician's time is precious, the appointment times can be short. And, you know, patients need time to digest the information. It's stressful. You're getting told about a diagnosis, possibly lots of information being thrown at you all in one short session. So just giving people time to consider their options. But I suppose as a nurse, and I'm a specialist cancer nurse, I think, you know, as part of my role, you know, it's very important that we advocate for the patients and that we help patients understand the information they're being given by the physician and to break down the side effects, what to expect, when to expect them, so they have an idea, but also using the information we have from our tools, from the geriatric assessment, to kind of give patients indications of, you know, risks of functional decline or cognition decline and quality of life. But I think, you know, and as Ray said, maybe giving patients more information on where to seek out further information that's maybe independent of the hospitals, like our cancer support centres or My Cancer. You know, our last talk was excellent as well, so Navigator. So I think it's just, I suppose, you know, just trying to bring it all together. I think it's just a very complex area, and I think it's multifactorial, but, you know, we have to kind of start somewhere.
Thank you, Michelle. Yes, there is first there is Nicolo who chatted the comment. Nicolo, do you want to comment?
Yeah, so yeah, I'll just join the panel discussion just to really echo Michelle's words. I think there is still a long way to go in terms of clinical implementation, and services like Michelle's in Waterford and several others around the world really have the big potential to improve, to enhance the opportunity to really have shared decision making in this patient population. We now have randomized control trials showing a wide range of benefits from a clinical standpoint, when patients are randomized to receive a wider MDT, multidisciplinary input. But also one of those showed also improvement in the uptake of advanced directives in this patient population. And my hypothesis is maybe that's because again, clinicians were more wary of embedding routinely patient goals of care in decision making. So I think that's another very strong point in favor of doing more work in terms of clinical implementation. Thank you.
Thank you, Nicolo. Ray, please go.
Michelle, one concern I have as a geriatric is that older patients are very, very proud people and they don't always tell the truth. How do you separate truth from half-truths in all of these conversations? And how do you actually ensure, as a separate question, that they have fully understood the question? Do you encourage doctors to play back the answer to the patient?
Good question, right? So yeah, no, I completely agree with you. I think I don't think it's limited to just older patients. I think, a lot of patients will maybe fudge the truth a little bit if they fear that, it might impact them getting a treatment or cancelling a treatment or postponing, or dose reducing. So we see it a lot. I suppose it all really comes back to kind of communication and listening to the patient and listening to the family and trying to see, sometimes you can see a family member nodding in the background, maybe in disagreement with what the patient is telling us. So maybe it gives us, kind of tweaks us that we can kind of change our line of questioning. I think patients don't hold back maybe some of the truth because of fear. So I think it's important that, we break down. I suppose I'm in a unique position where I am a cancer nurse that's involved with this clinic. So I know the impact cancer treatments can have on patients and the trajectory of the illness. But I suppose I can bring that to my discussion with patients as well. So I suppose it's yeah, I know, I agree. It can be difficult. It can be multi-complex. Does someone did I answer that for you, Ray? Was there anything else before Siri or Annika?
No, that's fine, thank you.
Siri, the last question.
Yeah, it was just a comment that
Yes.
a result found in a qualitative study that was done in Norway, that the older patients, these were patients over the age of 80 with colorectal cancer, the expectations they had were so low. So they said that even though they had lots of problems with their bowels after leaving hospital, after having surgery, and even during their hospital stay, they felt that the healthcare professionals were so busy and had other things, and they seemed so stressed, so they didn't want to bother them. So that's, I think that's really important to be aware of, that you have to ask, really not wait for the patients to ask you for help, but really be proactive with older patients because their expectations are far too low.
And time, isn't it? Being able to give time. We all don't have it, unfortunately, all the time.
Okay, thank you, Michelle, for having focus as well, and some of the most relevant clinical point about different perception and information. And now the question for Anneke van der Wal Wisman. I think that the pronunciation is correct. Anneke, you are a nurse researcher in UMCG Netherlands, and similar to Michelle, member of the Nursing and Allied Health Interest Group of the SIOG. With you, we would like to discuss about ageism. Could you explain the concept of ageism to everyone and how it impacts shared decision making? Thank you.
Yes, thank you, Sergio, for this question. Ageism towards older adults refers to the situation in which people are treated with discrimination, prejudice, and stereotyping because of their age. It's especially common in, well, ageism among older adults, typically above people aged 65 years and older. And it's very relevant in the context of cancer care, as it can impact how and whether older adults receive appropriate cancer care. Because of course, as you all know, cancer is prevalent among older adults because of age, and age is a strong predictor for developing cancer. And it's also important because ageism worsens healthcare outcome. So therefore, it's a very important and relevant topic. And as the WHO also specifies, is ageism towards older adults may include how we think, how we feel, and how we act towards people just based on their age. It's not really a visible problem, but it's more an invisible problem. And that makes it also quite difficult. In healthcare, ageism can lead to underestimating the autonomy and decision-making capacity of older patients. Healthcare professionals might assume that older individuals are less capable of making informed decisions about their care, or assuming they're less interested in active participation, for example, in their healthcare and also in treatment decisions. This, which all can lead to a reduced engagement in shared decision making. But ageism can also result in older patients receiving, for example, less information about their healthcare option. Sometimes it's assumed that older patients are not interested about all available options, or that older patients are not able to comprehend complex medical information. But it can also lead to treatment bias, for example. Types of treatment or intervention that are not recommended to older patients. And for example, healthcare providers suggest more conservative treatment options and avoid aggressive intervention, just based on age-based stereotypes. And that's quite important, and that limits also direct or indirect range of options for considering shared decision making. One thing, and Michelle also pointed this out, we know that a lot of guidelines for treatment are not based on studies, which include older patients. Older patients with comorbidities, for example, are often left out of studies. And therefore, we know that research in older patients are systematically and deliberated excluded from clinical trials, thereby expose them either to under or over treatment related to the lack of data on the responsiveness to treatment and risk of toxicities, for example. And this all can lead to poor cancer outcomes and reduced survival, for example. And we know that all the patients that already experience ageism may be less likely to actively participate in shared decision-making conversations because they feel disempowered or disrespected, as just also Dr. Ekman just told us that respect is so very important and empowerment is so very important. So it's regarding treatment decision making, it can be really a challenge to balance between under and over treatment, and therefore I think it's really important for healthcare professionals to be aware of ageism, be aware of their own culture or their own background, but also look at the patient's preferences and patient's goals and discuss it. Use nurses, for example, as Michelle also told about. Nurses are very well, patients talk a lot, of nurses tell a lot to nurses, and I think you should use that, but we all should be very well aware about our own attitude towards older people. So, and therefore I think it's training, as Siri also told us, I think training healthcare profession, being aware and integration of patient decision aids to discuss patient preferences, that can all help to mitigate ageism and the impact of shared decision making.
Thank you, and for this detailed answer about ageism and its impact on shared decision making. Are there questions? Yes. Edgar?
Yes, thank you very much. What, if I may say so, what strikes me is, thank you for all the inputs during this exchange of views, is that all the aspects that we stress are important for elderly people. In fact, they are important for every patient. I mean, what strikes me, it's like talking about low literate people. Yes, we have to make our, just giving an example, our leaflets readable. Yes, but every patient wants readable leaflets. So I mean, the principles they are giving indeed are totally right. Of course, someone who is of age is even more vulnerable and more dependent maybe than someone else. But in fact, what we are discussing about is how healthcare should be, I think, in general for every patient, I think.
Yeah, I agree to that. Absolutely. But I think regarding ageism, we just know it's specific a problem with the older patients.
Sure.
But of course, I completely agree with you. Yes, of course. Yeah.
Thank you. Ray?
Annika, in my experience, the older the patient is, the more that it is likely that the balance of power, if I can use that term, shifts from the patient's understanding of what they can say to a doctor to an expectation that the doctor will have all of the answers. How would you suggest that that is overcome if we're talking about having shared decision making?
Well, for me, it means that I agree with you. It means it stresses for me the extremely important role of the caregiver. I mean, if there is an imbalance in power, the one who has the responsibility of the one who has the power overweight becomes more important. I mean, it's easier to strengthen the patient from the point of view of the one who is the most powerful than the one who is less powerful, to try to be as vocal as possible. So it means that, but you all have, I think, stressed elements of it. It is active listening. It is taking the person into account as in a holistic view with all its circumstances. I saw in the chat, yes, if someone is living far away from the hospital, you have to take all these things in account. And I think and it is that is related to ageism too, but the same goes with prejudices towards other cultures or women. I mean, what you should do is look at the patient as a unique person. And indeed, I agree with you. Take into account that elder people do that are less full, maybe tend to a bit more undergo things. So it means, as a caregiver, listen. And of course, there is the issue of time. I understand that, but except from this, let's not stick to this challenge. It is a challenge. But you listen, you look. I stressed in the chat also the importance of non-verbal communication. I mean, look at the person. How do you behave? How does he behave? and a person is not an island. I mean, the people who are living around, they are coming with 2 or 3. Look at them. You will learn a lot from their non-verbal communication. But I agree, it stresses the importance of the caregiver, I think, and the healthcare organization. We are very often talking about the interpersonal relationship. In my view, you can be disempowered by the telephone center or at the billing service. I mean, you can be disempowered by all these ingredients of healthcare, I think. So we should consider it as a whole thing. I very often think that we have a lot of silos in healthcare, and the patient is the only one who really lives the healthcare system as one thing. I don't know if you agree with that.
I agree with what you're saying, and I also, regarding your question, Ray, I think it's very important to empower the patients, and I think that nurses can have a great role in that, because they are accessible for patients, but they also have a bit more time often in clinical practice to talk with the patient and also with the family members, because that's one thing we haven't discussed it yet, but I think family members are also very important to talk with, and to involve them in the shared decision-making process. So it's indeed, time is always challenging, very challenging, but we spend a lot of time. I work in a surgical department for operating on patients, for example, for a day, 8, 9, 10 or more hours, but we haven't got, or we don't make time to talk to a patient. So that's quite strange. Why spend 8 hours on a treatment, but don't spend time, for example, an hour on talking to the patient? So yeah.
Thank you to everyone. I think that we have to close this session because the time is over. I think so. Just if you will allow me, just one comment. The topics addressed were undoubtedly very complex and certainly deserve to be developed further. However, I think we should thank the speakers and their entire audience for the important contribution to the discussion, as they have tried to highlight how to deal with these sensitive topics and attempt to develop future actions. Thank you all, and I give the floor to Nicolo to conclude this webinar. Thank you again.
Thank you very much, Sergio. Thank you very much to all our panelists today. I think that was a very rich and thoughtful discussion that we had on shared decision making in geriatric oncology. I really identify a few golden threads of fil rouge, call them as you wish, around these aspects. I think what I feel is that we need definitely more training and education for healthcare professionals of any profession, really, around these aspects. There are resources that we can use, that we can leverage, but this is really a basic and pretty compelling need for our professions in oncology. I think we need also more awareness around shared decision making. This is something that Siri very, very eloquently highlighted, because sometimes we feel as clinicians that really all the patient need a bit of a stronger voice to engage with the discussions in the clinic, and we should really be more proactive around supporting these discussions when we meet them in the clinic. Communication is important, as Edgar mentioned, to really achieve shared decision making. And again, this is something, despite this is something that we perceive as so basic, as so fundamental. Actually, sometimes we feel that our healthcare systems are not always very well placed to give us the opportunity to engage in very detailed discussion around treatment options and patient preferences and so on. And as Michelle and Hanneke mentioned also, research, we need more inclusive research in oncology. We need more older patients, frailer patients in clinical trials, because obviously the benefits and the risk of harms that I'm discussing with the patients in the clinic may not necessarily be as easily applicable in real world older patients, at least those that I know from clinical trials. But I think we also need research around shared decision making in geriatric oncology, how we can best achieve this for older patients with cancer. And I like to think that these are really these areas really mirror what, for example, our top priorities in the field of geriatric oncology, and what our SIOG, International Society of Geriatric Oncology, feels are the top priority to advance the care of older patients with cancer at global level. It's about, obviously, clinical implementation. So again, give clinicians the time and the opportunity to really engage in decision making and patient empowerment for this patient population. We need more education and training. We need more research and more collaboration. I think we really highlighted this in our panel discussion from a multidisciplinary standpoint. So we need the input of our patients and caregivers. We need the input of a broader range of professions, including, obviously, geriatricians, nurses, allied care professionals, and so on, to really achieve this. So I would like again to thank very much obviously the Anticancer Fund, the International Society of Geriatric Oncology, for this fantastic webinar. I hope you found it very, very helpful. And on a final note, I'd like also to thank the EU Health Policy Platform for hosting this event today. I suspect this is going to be just the beginning for more work on shared decision making in geriatric oncology. So stay tuned. Thank you.
Thank you very much.
Thank you.